you guys to wait. But I'm Mike, and I'm a neurosurgeon here. I do vascular neurosurgery, and I run a research lab. And I talk to, I give a talk every year on some of the stuff that our lab is up to. And so I'm gonna kind of give you that information, and then I'll probably only be able to get through part of this, but I will put my email in the chat if there are any questions, or Julie can get a hold of me as well. So, all right. So you guys can all see my screen? Yes, no? Sort of. Okay. Okay. So we're going to talk about intracranial aneurysms and computational fluid dynamics. Here's my disclosures. It's just this thing we go through. So I'm part of the SAND Center, the Stroke and Applied Neuroscience Center, which is a organized research unit here at University of Washington, and there's lots of people involved from neurosurgery, neurology, mechanical engineering, bioengineering, radiology, etc. And a lot of people that are my lab, either alumni or residents or fellows that have worked on a lot of this stuff. So when I show you this work, just understand that it's mostly these people, and I just help them, and it's a big team effort. Okay, so we'll start briefly with aneurysms. So aneurysms are a weakened brain arterial wall. I think you can probably see there's a problem right about here. And the reason we care about them is that if they expand, then they can rupture, and they can cause bleeding in the brain. This is a CAT scan showing this white stuff is blood in the area around the brain, and that's called subarachnoid hemorrhage with acute hydrocephalus. So this is life-threatening. It can be very dangerous. About 20 to 30% of patients do not survive, and then a big number of the patients who do survive end up with disability. So there's a lot of work in trying to better treat aneurysms and detect them. So we treat aneurysms. There's a couple of different ways we do it. Surgical clipping, that's where we do an actual craniotomy, a surgery to remove part of the skull, and then using a microscope, get down and find the aneurysm, place one or more titanium clips across it. There's endovascular treatment, which is where we put catheters inside of aneurysms and fill them up from the inside. And there's a couple other ways we can do that. So that's the clinical treatment. My lab is really focused a lot on aneurysm hemodynamics. And so the idea there is we want to try and simulate what is happening in the blood vessels using a computer in order to understand the effects of blood flow. Because in reality, like, blood vessels are kind of just really fancy pipes. It's just plumbing, and blood flowing through it is liquid. And there's a set of equations that I don't understand, but that can be worked on using computers to sort of give you an idea of what's happening in the blood vessel and the forces that are acting on the blood vessel wall. And that's what we use to study aneurysm formation, growth, and rupture. So we can also measure the effects of treatment. So the main takeaway, I think, from this talk is that, what we're trying to do is recreate in a computer what is happening in the brain or in the brain blood vessels. And then we can use that as a test bed to sort of study, why certain patients develop problems and others don't, or how effective treatment is, which is really my lab's main focus. And that leads us to better understand what the effects, like if we do a treatment, what's going to happen, and also maybe to develop better treatments. So in order to do that, we need to learn a few terms. So wall shear stress is probably the most important term for fluid dynamics. And it's the pressure exerted by blood on a vessel wall. So I know this looks very intimidating, or at least it does for me, lots of Greek letters and equations. But really, if you think about a blood vessel like a river, with water flowing in the river, and then like a sandy bank on the side. Sorry, chief calling me. So imagine this blood flowing through, and the pressure, or sort of force, actually stress, exerted on the riverbank that erodes the sand on the riverbank. That's what we're talking about as wall shear stress. So when there's blood flowing through a blood vessel wall, there's a little bit of drag on the blood vessel wall itself, and the body and the cells sense that, and that can become a problem. So we think there's a variety of things as a simplification, but high wall shear stress creates those outpouchings that become aneurysms. And then low wall shear stress is in many ways just as bad. When there's turbulent flow or low flow, the body doesn't like that either, and the blood cells that line the blood vessels can become dysfunctional. So this is a kind of a cartoon of what's going on inside the blood vessel at the cell. So there's increased stress due to flow that sort of activates some of these monocytes and creates an inflammatory or creates an erosion and causes an outpouching that looks like this, a leaky vessel. And then there's disruption of the internal elastic lamina, which is sort of the inner lining of the blood vessel. That's made worse by low flow or turbulent flow, and that causes problems. So how do we do computational fluid dynamics? First, we start with a 3D model of an aneurysm and vessel. And when I say 3D model, I mean a scan. So this is actually a scan from an angiogram, and then we put the patient's blood flow and pressure into the computer as inputs. And then as an output, we get maps that look like this. And so this is a blood vessel, so the patient laying on his back, blood flowing up towards the top of the head, flowing through the normal blood vessel. This is the aneurysm, and the blood is sort of jetting into this area here. So this area is experiencing a lot of shear stress. And then it's slow over here, like eddies, like in a slow river, and that's where the area is experiencing low wall shear stress. So I think the one thing that we had kind of really focused on in our lab is that a lot of these models use reference values of blood flow and pressure as inputs. So we take scans of young, healthy volunteers, typically college students like yourself, who sign up to get paid $50 to have an MRI, and then we measure the blood flow of in the blood vessels in your brain, and then we use that to make our models. But the problem there is that these aneurysms are a disease typically of patients who are in middle age or older. And so if you imagine a 65 or 70-year-old patient with high blood pressure and other medical problems, their blood flow is not going to be the same as your blood flow, for instance. It's going to be very, very different. And so you can't really generalize these things, but a lot of people do because it's hard to get a patient's own blood vessels. So the problem here is that small inaccuracies in inputs have a very large effect on the calculations of hemodynamics, because the equations that we use to calculate wall shear stress often have an exponential component to them. And so if you make a little problem at the beginning by assuming that the blood flow is 10 instead of 20, that can have a very large effect on the calculations. It's sort of like a butterfly effect.
Dr. Levitt, Evan has a question.
Oh, sorry, go ahead.
I just had a question about like in terms of like the morphology, like the shape, as well as like kind of location in the brain. Like how does that affect like your model?
So the morphology, the location doesn't really matter that much. We have a whole brain scan, so we can take it from any location. The morphology we incorporate into our model because we use a patient scan, so we get the shape, and the shape is important for calculating the hemodynamics. So our solution here to fix this problem of inputs is patient-specific measurements. So what we're really focused on here is we want to fix this assumption, this problem that using college students' blood pressure is somehow relevant. And so, sorry, this is the problem when you are trying to do this on call. So there's a couple different ways. I'm going to skip through this. There's a couple different ways to measure blood flow in a blood vessel. The problems is that they're not very useful and they're not very accurate. So what we decided to do was, when we were doing these angiogram tests, which are catheter tests, we were going to put this little wire up into the blood vessels, which is basically a little radar gun. So we put the wire up into the blood vessel, and we can actually measure blood flow from the tip, and we can measure pressure, and we get this nice readout that has blood flow and blood pressure on the top. And we can incorporate that into our tests. And I'm gonna skip this in the interest of time. But what we did was we compared a couple of different modalities, and we found that this wire is pretty good at predicting what we think it's going to predict. So the point here is that instead of using off-the-shelf sort of generic blood pressure and flow to make these models work, we're going to use a patient's own blood pressure and flow, and we think that's going to be more accurate, right? So is it more accurate? So the first thing we did was we kind of tested that. And the way we did that was we started with 10 patients with aneurysms, took the pictures of their aneurysms, the volumes of their aneurysms from their scans. And then we did two separate simulations in the computer. One, we used the standard reference values from a book, like blood pressure and flow are X and Y. And then the next one, the same patient, but a different model, we used their own blood pressure and flow measurements. And then we just compared how accurate the models were compared to the outflow at a given point. And I'm not going to go over how these statistics are done. This is a Bland-Altman plot, but basically the closer the dots are to each other and to zero, the better and more precise the measurement. So this was with the wire-based calculations, and this was with the sort of general off-the-shelf references. And so I think if you look at these two, you can sort of see that these measurements are much tighter. There's more precision. You're more likely to get an accurate, a real reflection of what's actually happening. Here, they're kind of all over the map. There's lots of outliers, lots of variance. So it's just going to affect your calculations in really unpredictable ways. And we looked at wall shear stress in a variety of different ways using both the patient-specific measurement and the simplified measurement. We found a big difference. And what that looks like in practice is here's an aneurysm, here's a blood vessel with computational fluid dynamics, and this is the wall shear stress map. So you can see the wall shear stress with the patient-specific measurements, and then this is with the sort of standard values. So, you know, it's a really big difference in terms of what's actually happening in this patient's blood vessel. If we just use the standard off-the-shelf numbers, we're going to get a really incorrect simulation, and so we don't want to make clinical decisions based on that. So then what we did was we wanted to measure the effects of, well, actually I'll pause here and see if there are any questions. No questions. Okay, so what we did next is we wanted to, so we kind of said, okay, this is going to make it more accurate. That's great, but like, how is that going to help us clinically? So then what we're really interested in here is some percentage of aneurysm treatments don't work. The aneurysm doesn't go away. And we do the treatment through the blood vessel, and for whatever reason, the aneurysm it grows back or it stays open and the treatment fails. And so what we wanted to do is understand, can we make computer simulations that then can predict at the time of treatment that the treatment is going to succeed or fail? So during aneurysm treatment, we put this little radar gun at different places in the blood vessel, and we measured blood flow and pressure before and after treatment. And then we end up with a CFD simulation that looks like this. So this is before treatment, here's an aneurysm. And then after treatment, you can see a big change, a big drop in wall shear stress, a big drop in velocity, which is good. That is, theoretically, that means that the aneurysm is going to go away. And then the last thing I want to get into, so we use this and we're sort of exploring whether this can predict outcomes. We're still in the process of that. There's an active grant going on to collect lots of patients and understand that. And I think the last thing I'll talk about in the time I have left is something that was really cool at the time, which was to reduce the uncertainty of modeling aneurysm coils. So when we coil aneurysms, I'm going to skip through this, but coiling is when we put little wires into the aneurysm to block it off from the inside. These coils are really small, and you can't see them with normal scans. And here, I'm going to get to the good part here. So this is what a CAT scan looks like with an aneurysm coil in it. It's this fireworks because the coils have metal in them, and they react with a CT scanner and make it hard to see. And so what we did was we wanted to get a really good picture of what coils look like when they're deployed. There's not a good way to do that in a patient because the CAT scans don't look very good, MRIs don't look very good. So what we did was we created some 3D printed models of actual aneurysms, and then we filled them with little actual coils, and then we can image them in interesting ways. So there's this thing. It's called the synchrotron X-ray or synchrotron research facility. It's a particle accelerator in France. And I don't know, why does this have anything to do with neurosurgery? Well, you can make that particle accelerator act like a really, really good CAT scanner. It has a really high energy X-ray and an imaging resolution of about 12 microns. And importantly, no beam hardening artifacts. So it doesn't make that little scatter like what you see here. Now, you can't put a patient in that. That's how a lot of superhero origin stories start. But in reality, it would really hurt somebody. This is a research facility. But it is useful for getting, this is what it looks like, by the way. It's in the middle of town in Grenoble. I highly recommend you go visit. It's very beautiful. So what we did was we took this 3D angiogram and we made a 3D printed model. And then we created a cast around it to make a wax cast. And then we created a negative model because what we wanted was the space where the vessel was, right? So we created this tube with an aneurysm on it. And then we filled that aneurysm with actual little coils like this. And then we scanned them in this synchrotron and we ended up with pictures that look like this, which is very detailed of these tiny, tiny little wires. And we can use that to do some modeling of the effects of blood flow before and after coiling. So normally what we do is we treat these coils as sort of a uniform, what we call porous medium, where the aneurysm is filled up, but we don't know exactly where each wire is. We just sort of guess. Here with this method, we can actually place an actual picture of the actual coils in place. And you can see that there's a really big difference in how we model flow with a computer if we have the real coils. And we showed that this had a big change in sort of the accuracy of the modeling. And we then developed a way to sort of model this more accurately in people. I'm gonna probably hold off there because I'm gonna have to run to the operating room. I know I'm cutting this a little bit short. I wanted to see if people had questions about this or the research process in general that I could answer, and then to follow up with me over email if there's any questions, because unfortunately I do have to go. Questions for me? I know it was a lot of information.
Yes, one person has a question.
Yeah.
Hi, well, thanks for your time today. I know you're very
Yeah.
busy.
Sorry.
Um,
Yeah.
no, you're good. I was just curious, like the beginning of the presentation when you were talking about like the kind of more individualized approach to treating these aneurysms, do you see that eventually becoming like the standard of care? And if so, how long would that take to become the reality?
You mean the using these simulations?
Like using the patient's data for the different parameters you need to calculate the shear stress and all of that versus the standard values.
Sure. 1 second. So it's probably not going to be the standard of care because it's an extra step that adds a little bit of time and risk to that procedure. What we have done is we've used those measurements to understand how patient factors like blood pressure, age, and other things affect blood flow in the brain. And what we're hoping is if we gather enough of those patients, we can actually kind of estimate. We can look at somebody like you and say, well, your blood flow is probably going to look kind of like this. Somebody like me, it's going to look a little different. Somebody who's older with high blood pressure, who's a smoker, it's going to look even more different. And what we want to do is kind of get away from the invasive nature of that research process into something that's more clinically applicable. So this is really not something we can do to everybody, but in our research setting, it is the place to start to build that foundation. So it's a good question. Other questions? Are you guys having a good experience this summer? Yeah. I mean, we have 2 people in our lab. They seem like they're having a good time. right? No, shake your head. Terrible,
No.
terrible experience. Yeah. It's always so fun to uh, hang out with you guys because every summer, everybody comes at this with like a different attitude. But and I'm really sorry that I have to cut the talk short, but I have definitely I've given this talk or something similar to it, and I've had people with no sort of engineering background ask like extremely insightful questions. And the one thing I wanted to emphasize before I go is um, people like me get up here and talk about how like we do this science and it's all, this is the steps and whatever. And it seems like it's a very linear path. Like, well, we started by doing this and then we did that. And then from there we did this. And it was like, oh, I always knew I was going to get there. That is not how science works at all. Usually what happens is you end up like asking some question and then you're like, you assume somebody has probably answered that question. Like somebody out there has probably thought of this before. And most of the time they have, but sometimes they haven't. And you look around and you're like, really? Like nobody's looked at that? Like that seems weird. Like we should look at that. And then you look at it and you're like, oh, this is cool. Like we figured something out. And then you publish it. And then you're like, as you get in the process of answering that one question, like more questions will crop up. So I've been doing research now for like 15 years, 14 years. And like where we started versus where we are now is like really different. And I would never have expected to do the kind of research that I'm doing at the start. You don't have an end goal in mind. What I want to kind of impress upon you guys is like, number one, you don't need an advanced degree to ask good questions. You just need curiosity and enthusiasm. Like that's what you really need. And number two is just be naive enough to try. Like don't think, oh, I'm a nobody. I couldn't possibly make a contribution, or I don't know anything yet because I haven't gone to graduate school or whatever, so I can't do science. Like don't think about that at all. Like just be curious, be enthusiastic, and you'll find that will get you like 90% of the way. Because if you're curious, then you'll want to figure it out. It'll bother you that you don't know the answer, and that's what makes progress happen. So I guess that's kind of like, I never expected to be involved in research when I was in medical school. Like I do not have a research background. It's like, oh, this is cool. Like it's fun, it's creative, and it's not, nobody's answered this question yet. Why not me? And I think that's the thing that will keep you guys going if you want to do science in your career, which hopefully you do if you're here. So, other questions before I run off to the operating room and do not as fun things as this? No questions. All right. So we will.
Dr. Levitt.
Yeah.
Thank you, Dr. Levitt.
Oh, sure, my pleasure. So I'll see you guys at your presentations. Our whole lab likes to go and show up in support, not to make you guys nervous, but to cheer you on. And so I'm looking forward to hearing about all of your experiences. And like I said, Julie can give you my contact info if you have other questions to follow up. I'm very sorry. I really do try to block this time out. But I just got kind of caught between some emergencies, so I do apologize. But we'll talk again, and good luck to everybody, and we'll see you at your presentations. Okay. All right. Thanks a lot, guys. See you later.
Thank you.
Bye.